Hello, my name is Melissa Picard. I'm an abdominal imager at the Medical University of South Carolina in Charleston, and today I'm going to give you a little talk on urinary tract trauma. So in this lecture, we will cover adrenal trauma, renal trauma, including trauma scoring and a few special cases of vascular and collecting system injury, as well as bladder trauma and urethral trauma. So to start off with adrenal trauma, this is relatively uncommon and is more often unilateral than bilateral, and more often involves the right adrenal gland compared to the left. In this example on the left side of the screen, you can see the right adrenal gland is enlarged, consistent with a right adrenal gland injury. And then here on the right side of the screen, the left adrenal gland is enlarged and irregular, consistent with injury to that gland. Now, the mechanism for adrenal trauma, particularly why the right is more affected than the left, has a few theories. The first is that increased intra-abdominal pressure gets transmitted through the IVC and then through the shorter right adrenal gland vein, leading to injury of that particular gland. Another explanation or theory is that direct compression of the right adrenal gland between the liver and the posterior abdominal wall is often a cause of ipsilateral injury to the right gland. So management of adrenal trauma is usually non-surgical unless there is active hemorrhage present. So you can see here is another example of a right adrenal gland hematoma. And then here's another example, again with hemoperitoneum, the adrenal gland remains asymmetrically enlarged. So complications from adrenal trauma are usually incidental and not very common. Adrenal insufficiency is rare and would only occur in the setting of bilateral adrenal injury. Moving on to renal trauma, the incidence is about 10% and is often due to blunt trauma. 80% of renal trauma have multi-organ trauma, and the majority of renal injuries are going to be contusion, accounting for about 80%. Hematuria is present in 95% of those with renal injury. About a third of patients with UPJ injury will present without hematuria. So reasons for obtaining a CT in patients with suspected renal trauma would be patients with gross hematuria, a patient who has microscopic hematuria in the setting of hypotension or other associated injuries, in the setting of penetrating trauma where the kidney would be in the path of injury, and then hematuria in a pediatric patient would warrant a CT looking for potential underlying renal trauma. So renal trauma can be graded between levels 1 through 5. So a grade 1 is considered either a contusion or a perirenal hematoma without any parenchymal laceration. So you can see the example here in the yellow box. The right kidney has contrast and is enhancing, but there are these kind of wedge-shaped areas of decreased enhancement consistent with renal contusions. This would be a grade 1. In the example in the blue box, you can see that there is a perirenal hematoma, but the renal parenchyma is underlying that hematoma is preserved. So this would again be consistent with a grade 1 renal trauma. Moving on to grades 2 and 3. When we move to grades 2 and 3, we now have parenchymal laceration or defects, and the difference between grades 2 and 3 has to do with the depth of the laceration. And for both of these, there is no underlying collecting system injury. So a grade 2 is going to be a cortical laceration that is less than 1 centimeter in depth. So in this orange box here, you can see there is a defect within the renal cortex that is less than 1 centimeter. So this would be a grade 2. And then the example in the blue box, you can see there is a defect, a laceration through the upper pole of the right kidney, consistent with a grade 3, given its length of over 1 centimeter. And on the delayed excretory phase imaging, there is no evidence of contrast extravasation to suggest collecting system injury. So this would be a grade 3. Here's another example of a grade 3 renal injury. So again, there's a cortical laceration that is over 1 centimeter in depth. You can see in this example, and on excretory phase imaging, no evidence of contrast extravasation, so there's no collecting system injury. And then again, another example, there's a large cortical defect within the right kidney with a large perirenal hematoma. But again, on excretory phase imaging, you can see there's contrast here. There's no evidence of contrast extravasation or underlying collecting system injury. Moving on to a grade 4 renal injury. At this point, there are several ways to achieve a grade 4 injury. You can have a laceration through the cortex and the medulla, but at this point, you would have to add collecting system injury, as in the example below. You can see that there is a large perirenal hematoma with multiple areas of area of cortical defect here in the anterior aspect of the left kidney. And on excretory or delayed phase imaging, you can see there is contrast extravasation. So we have a laceration through the renal parenchyma with injury to the underlying collecting system consistent with a grade 4 renal trauma. You can also have a segmental infarct, would be categorized as a grade 4 renal injury. So you can see there's a large area of non-perfused part of the right kidney. So this would be a segmental infarct. You can also have grade 4 injury when you have underlying injury to the main renal artery or the main renal vein. So in this example, you can see this is the aorta with contrast extending into the left main renal artery, and there's this small outpouching or pseudoaneurysm as a result of trauma. So this would be a grade 4 injury. There's no evidence of active hemorrhage outside the vasculature. And the most severe renal trauma would be grade 5. And this would be due to either one, a completely shattered kidney, as in the example below. You can see there's a large perirenal hematoma around the right kidney, multiple cortical defects dividing the kidney up into several different pieces, consistent with a shattered kidney. And here's another example of the same thing, multiple defects throughout the kidney, leaving the kidney in multiple pieces, consistent with a grade 5 injury or shattered kidney. You can also have a renal hilar avulsion, which leads to a devascularized kidney. This would be considered a grade 5 renal injury as well. As you can see, there's contrast within the abdominal aorta, contrast perfusing the left kidney. However, the right kidney is not perfused at all and looks pretty much the way it would on a non-contrast image. There's this hemoperitoneum surrounding the right liver, or right lobe of the liver. So this would be consistent with a devascularized kidney or grade 5 injury. So the management of renal trauma depends on the grading. So grades 1 to 3, remember these are either contusions or lacerations without any underlying collecting system injury. These are managed non-operatively in 75 to 98% of the time. Grade 4 will have lacerations but also have underlying collecting system injury. So there are urine leaks associated with the grade 4 injuries. So 80 to 90% of the urine leaks will resolve spontaneously. So these tend to be managed expectantly with follow-up imaging in the next over a couple of days. At times, stenting or percutaneous drainage may be needed, but they do tend to be managed more conservatively. If you have a grade 4 or a grade 5 injury that either has an underlying vascular injury or a shattered kidney, these may be managed either with interventional radiology or operatively, depending on the underlying condition. Okay, here's a few special cases, this is one of active hemorrhage. So active hemorrhage needs to be delineated from collecting system injury, and that has to do with when you see the contrast being extravasated. So on this early phase image, you can see there's contrast within the vasculature and the aorta. There's also contrast within the parenchyma, but there are multiple defects within the left kidney and several areas of linear contrast extravasation seen on the early phase. And on delayed phase, you can see that the contrast is not seen brightly there. So this would be an example of an active hemorrhage. and not a urinary leak. Here's another example of an active hemorrhage. So you can see on this earlier phase of contrast, there is high density material or contrast extravasating out medially around this right perirenal hematoma. Again, high density contrast. On the delayed phase, you can see there's contrast, very bright contrast within the collecting system. However, there has been an increased amount of contrast more medially here, and it tends to be following blood pool consistent with active hemorrhage and not collecting system injury. Another example of a vascular injury related to renal trauma can be venous. These are not as common and tend to be due to or associated with vascular pedicle injuries. You can see here on this axial phase, there's some stranding and soft tissue or fluid around the left renal pedicle. On coronal imaging, you can see this linear defect within the left renal vein consistent with thrombus. And there's also this left renal hematoma, perirenal hematoma. Okay. Moving on a little bit to ureteral trauma. About 2% of urinary tract trauma is ureteral injury. 38% of those are due to blunt trauma and can be associated with pelvic and lumbar fractures. The remaining 62% are due to penetrating injuries and can be associated with bowel injuries or venous injuries as well. In this example here, you can see there's a metallic bullet fragment in the left pelvis from a gunshot wound. And you can see that there's retrograde or antegrade filling of contrast within the left ureter, and there is outpouching or extravasation of contrast here consistent with ureteral trauma due to penetrating injury. Here's an example of a collecting system injury at the UPJ, the ureteropelvic junction. You can see here that on the earlier phase of contrast, we don't see any contrast extravasation at this point. But as we get into the delayed phase, there is contrast that is seen outside the collecting system at the level of the UPJ, consistent with a UPJ injury. If we look a little more distally, we can see there is contrast within the distal ureter, suggesting that this is a partial disruption of the UPJ as opposed to a complete. In a complete disruption, we would not expect to see contrast within the distal ureter. It's important to know that there are some pre-existing abnormalities that can predispose the patients to injury or the organs to injury. This would be an example of a horseshoe kidney. Given its low position down in the abdominal pelvic cavity, it is no longer protected by the ribs and so is predisposed to trauma, just given its location. So you can see here's an example of an uninjured horseshoe kidney, and then here's an example of trauma with devascularization of the left kidney compared to the right. You can see this is non-enhancing as opposed to the right aspect. Okay, you can have complications from renal trauma. One complication would be a urinoma when there is a disruption of the collecting system. These can be managed by stents or drains. Here's an example of a patient who had disruption, defect within the right kidney, and then on excretory phase imaging, you can see there is contrast extravasation consistent with a urinoma. This patient then underwent a drain placement. Hypertension is another complication of renal trauma. It's not very common. It can either be due to vascular compromise or injury or due to underlying compression of the renal parenchyma, such as a Page kidney. Moving on to urinary bladder trauma. Urinary bladder trauma is classified based on where the leak is located. About 2/3 are going to be extraperitoneal in location, 1/3 approximately will be intraperitoneal in location, and a little less than 5% will be combined. Over 2/3 of urinary bladder trauma are going to be due to blunt trauma or blunt injury. In the diagnosing of bladder injury, cystography is the study of choice. So historically, we would have done routine cystography with fluoroscopy, as you can see in this example. Catheter is placed into the urinary bladder. Contrast is retrograde and stilled, and then imaging is obtained to look for extraluminal contrast. You can see here in this example, as outlined by the orange arrow, there is contrast extending outside the bladder lumen, consistent with a bladder perforation. More often today, this imaging is done with CT, a CT cystogram. The technique is similar, and in that you would place a Foley catheter into the urinary bladder and then actively distend the urinary bladder with contrast. Ideally, you'd like to get 300 to 350 cc's of contrast in order to adequately distend it. Passive distension of the urinary bladder from antegrade excreted contrast is insufficient or to adequately assess for bladder perforation, so performing a formal cystogram is the study of choice. With CT cystogram, post-drainage imaging is not required because CT allows us to see in and around the urinary bladder just through its technique. So when we talk about extraperitoneal bladder perforations, pelvic fractures are associated with 90 to 100% of these types of bladder injury. Penetrating trauma is often another mechanism for extraperitoneal bladder rupture. The mechanism is usually a shear force from deceleration, and bony perforation is now thought to be a little less common. You can see here in this example, there's a fracture through the right ramus, inferior pubic ramus, and there's contrast extravasation outside into the perineal spaces and then even into the right aspect of the medial thigh. Extraperitoneal bladder ruptures can then further be characterized into simple versus complex depending on the extent of contrast. So a simple extraperitoneal bladder perforation is where contrast extends around the bladder base into the perivesical space in this molar tooth distribution. So you can see here in this example, there's contrast within the urinary bladder, Foley catheter is in place, and there is contrast extending up and over in the perivesical space, much like the appearance of a molar tooth. Here's another example, similar appearance, contrast outside the bladder lumen on both sides but remains contained in the perivesical space. A complex extraperitoneal bladder rupture is where contrast extends into the thigh, the penile region, the perineum, or even into the anterior abdominal wall. You can see in this example here on the right, there's contrast outside within the perivesical space, but then also extending down into the perineal region and then also into the right medial thigh. Here's an example of contrast in the perineal region, the penile region as well, and then into the anterior abdominal wall. So this would be a complex extraperitoneal bladder rupture. Intraperitoneal bladder ruptures are due to a direct blow to a distended bladder. So these tend to be alcohol-related and seatbelt injuries most often. With alcohol, the patient's diurese and the urinary bladders become markedly distended. And then when there's an accident or a motor vehicle accident and the seatbelt injury will compress on the urinary bladder, and much like a water balloon that's distended, if you rapidly push on it, you'll blow out and rupture the top of the water balloon, or in this case, the urinary bladder. These are typically horizontal tears along the bladder dome. Intraperitoneal bladder ruptures result in urine leaking into the peritoneum, and with that comes some complications, including hyperkalemia, hypernatremia, uremia, and acidosis, as the urine gets absorbed by the peritoneal lining back into the blood system. These patients may appear anuric, even though their kidneys are working. The urine is going into the peritoneal cavity instead. You may have extravasation of contrast. Because there's extravasation of contrast into the peritoneum, you will see contrast outlining loops of bowel within the paracolic gutters, and even into the rectovesical and rectouterine pouch. So here's an example of an intraperitoneal bladder rupture. You can see there's contrast within the urinary bladder in both these examples, but there's contrast extending up into the paracolic gutters and then also extending around and outlining loops of bowel. Here's another example of contrast within the peritoneal cavity, consistent with intraperitoneal bladder rupture. You can see contrast outlining loops of bowel. In this case, axial images may fail to show where the actual defect is, so make sure you're looking at coronal imaging or sagittal imaging to try and identify the location of the defect. You can see here in the coronal image or coronal plane, you can see a defect in the bladder dome. Here's another example of intraperitoneal bladder rupture. Again, contrast outlining loops of bowel outside the bladder lumen. And this one is associated with pelvic fracture. So you can see there's disruption of the pubic symphysis and then also a fracture of the pelvic bones. You can also have a combined rupture, which is both intra and extraperitoneal components. So in this case, there is extraperitoneal bladder perforation with contrast extending into the perivesical space, and the coronal imaging shows a defect in the lower or inferior aspect of the bladder. But as you can also see, there is contrast with surrounding loops of bowel consistent with an intraperitoneal bladder perforation, and on the coronal imaging, there is a defect in the bladder dome. So because there's both intra and extraperitoneal components, this is considered a combined rupture. Combined ruptures are going to be at high risk for other visceral or vascular injuries. The mortality rate is much higher at 60% compared to 20% with other bladder injuries. Combined ruptures can be secondary to blood trauma, but are frequently due to penetrating injury. And the management of bladder trauma has to do with the location of the rupture. So intraperitoneal bladder perforations are managed surgically, and that has a lot to do with the complications that come from the uremia and the hyperkalemia and from having urine within the peritoneal cavity. Extraperitoneal bladder perforations are usually managed conservatively with Foley or suprapubic catheter decompression. Most of these will heal within 7 to 10 days and the majority within several weeks. If there is a more extensive bladder rupture or if there's a bony fragment or a foreign body that would prevent healing, these may require surgery. And a combined bladder perforation would be managed surgically as well, predominantly due to the intraperitoneal component. When we talk about bladder and urethral trauma, over 10% of men who have a posterior urethral injury have bladder injury. So if you see as a clinician blood at the urethral meatus, that suggests that there may be underlying urethral injury, and a retrograde urethrogram would be, or a RUG would be the imaging study of choice to assess for urethral injury. So in this setting of blood at the urethral meatus, there should not be an attempt to blindly catheterize the patient. So urethral trauma, the mechanism can either be due to pelvic fractures through motor vehicle collisions or falls, and that tends to involve the membranous urethra and can be due to shear injuries. Another mechanism would be a straddle injury, which would be direct trauma, mainly to the bulbar or bulbous urethra, and there are usually no pelvic fractures associated with straddle injury. So urethral trauma is going to be categorized or classified based on which parts of the urethra are injured. So it's important to remember the anatomy of the male urethra. So it is divided into the posterior and the anterior urethra. The posterior urethra consists of the prostatic urethra and the membranous urethra, which courses through the UG diaphragm. And the anterior urethra is composed of the bulbar or bulbous urethra. And then after the penoscrotal junction, you have the penile urethra out to the external meatus. Okay. On a VCUG and a RUG on fluoroscopy, knowing your landmarks for where the UG diaphragm is going to be very helpful. So if you draw a line at the inferior aspect of the obturator foramen, that is approximately where your UG diaphragm will be. So everything above towards the bladder neck is considered the posterior urethra, and everything below would be considered the anterior urethra. On a RUG, the same thing. You draw your line through the lower aspect of the obturator foramen. Everything above is the posterior urethra. Everything below would be the anterior urethra. So urethral trauma is graded on types 1 through 5, and that has to do with where the injury is located. So a type 1 urethral injury involves the posterior urethra, but it remains intact, it's just stretched. A type 2 urethral injury is a tear in the posterior urethra above the UG diaphragm, and it can be partial or complete. A type 3 urethral injury involves the membranous urethra and extends into the bulbar urethra anteriorly. A type 4 is a bladder neck injury that involves the urethra. A type 4A is an injury to the base of the bladder that has periurethral extravasation, so it looks like the type 4 bladder neck injury. And then a type 5 is a purely anterior urethral injury. So here are examples of type 1 and type 2 urethral injuries. So type 1, remember, involves the posterior urethra, which remains intact but is stretched. You can see there's disruption of the pubic symphysis. There's contrast seen within the urinary bladder and within the posterior urethra. However, there is no extravasation of contrast, so it is intact. It's just elongated and stretched, so type 1. Type 2 is a purely posterior tear. Here's an example of a partial and then one of a complete. So you can see there is contrast within the penile and the bulbar urethra. We reach the UG diaphragm here, and the disruption is posteriorly within the posterior membranous and prostatic urethra. So this is a purely posterior tear, type 2. You can see there's still contrast extending up into the urinary bladder, so this would be considered partial. As opposed to this example where your UG diaphragm is at this location, there is complete contrast extravasation of the posterior urethra, and there is no contrast seen entering the urinary bladder, so this would be a complete type 2 tear. Here's another example of a type 2. You can see there is contrast in this retrograde all the way to the UG diaphragm, but then there is no contrast seen proximally within the posterior urethra. Again, consistent with a type 2 tear. Another example, here's an example of a type 3. So this is combined anterior and posterior. So here's a partial. There is contrast extravasation within the anterior urethra, and also involving the membranous urethra. But there is a little bit of contrast still seen entering the urinary bladder, so this would be partial. And here's a complete type 3 involving both the anterior urethra and the posterior urethra with no contrast seen more proximally. It's a complete type 3 urethral disruption. Urethral trauma to the female urethra is much less common given the short length of the female urethra. However, it does happen, and this is an example of a 92-year-old female who had an injury to both her bladder neck and the urethra. You can see here there is contrast extravasation outside the urethra. You can see it here posteriorly. So this would be a female urethral injury. Type 4A is where the urethra remains intact, but the base of the bladder has been ruptured, and this simulates a urethral injury. As you can see here, there's contrast seen outside outside the urinary bladder and outside the urethra. Here's another example of contrast extravasation at the bladder base, simulating a urethral rupture. And a type 5 is a purely anterior urethral injury, and this is usually due to a straddle injury. So you can see here, this is below our mark for the UG diaphragm. So this is purely anterior. There's marked enlargement and extravasation of contrast consistent with a type 5 urethral injury. Here's another example of a purely anterior urethral injury. However, this is secondary to a gunshot wound. You can see our landmark for the UG diaphragm would be at this level, and then there's a bullet fragment and a disruption of the anterior urethra. Urethral injuries are treated usually with delayed surgery. There may be an initial attempt to realign the urethral segments using either a catheter or potentially even requiring a cystoscopy to align the two areas. A cystostomy may be performed if needed. Exceptions would be if there is an intraperitoneal bladder or rectal injuries associated with it. And that is what I have for you for GU tract trauma. Thank you very much.